I tell you what, keep them and let's see how you did on them, okay? Let's see how you did on them. Hey, by the way, I've got some people who aren't doing the, and y'all know who they are because y'all can see who's doing the study guide. So y'all know who of your peers are not doing them. So I can tell you that they can help you if you let them. Okay. Also, sometimes I know the recordings don't come across. And so like in micro, the recording in that room didn't work the other day, but I think these have been working. So in here, we've missed a couple from the micro room, but computer. But you guys want to stay up. We're going to have the test on this. What did I say? A week from today? A week from today, this test, and all of these questions, I feel like were fair. This will also mean that the people who are out today, if you all are listening, you really are not missing a quiz today, a quiz grade. Sorry you're sick. Don't bring anything in here, especially stomach bug. But anyway, I think these were all fair. So let's see if you can get this today, okay? Or go back, you'll know where your weakness is and go back. I had asked you to know the difference between a TIA and a CVA. TIA are transient ischemic attacks. They used to be called little warning strokes or mini strokes, but now they're considered a stroke. The difference between a transient ischemic attack, and if you broke those words down, if you looked at those words, transient means comes and goes, right? Ischemic means lack of blood supply, and that means it's attacking the tissues. Those signs and symptoms can go away after so many hours. Usually you hope they've gone within 48 hours or so. Sometimes it can take a little bit longer than that, where cerebral vascular accident is going to cause enough damage that you're going to, if you survive this stroke, you are going to have permanent consequences from it. That's the difference. Make sure you guys could discuss that and teach it to somebody. The terms systole and diastole, these terms, systole means contraction, diastole means relaxation. When the left systemic circuit cannot keep up with the pulmonary circuit, and so y'all knew exactly what that meant, the left systemic pump versus the right systemic pump. When the left can't keep up, the right is still pushing blood at the same pace, but blood is going to back up in the where. So where are you going to get edema? Lungs, and that's called pulmonary edema. What is an aneurysm? It's a weakened wall of a blood vessel. I didn't ask you what the risk of it is, but what's the risk? That it can rupture, it can burst, right? And depending on how close that rupture happens to the heart, or if it's near vital organs, like in the brain, then it can be really quick death, right? You guys know, so aneurysms are serious. Define hypertension and give the blood pressure associated with this diagnosis. Hypertension just simply means high blood pressure, and according to the American Heart Association, that's anything this and above 140/90. So the top number is systole, the bottom number is the diastolic number, right? So define arteriosclerosis. What did you put? All you had to put was hardening of the arteries. Is that right? How are you doing so far when it's like a, it's not really a discussion, it's me yelling at you. No, but I'm not yelling. I'm just trying to maybe say it clearer. So, and you guys are writing it down. Are you going to use it? Are you going to have all these on the test Wednesday? You're going to have all of this plus more on the test. So what is medical shock? Shock means dangerously low blood pressure. Dangerously low blood pressure. And what's the most common cause? Hypovolemic shock. Now, you know some reasons for low blood volume, hypovolemic shock. Some reasons are what? Trauma. What's the most common reason? Supposedly in our country where we have water at our fingertips. Do you know how fortunate we are that we have water at our fingertips? Most countries people don't have that. Water is their limiting resource. That is their limiting resource. But we have it at our fingertips, and it's estimated that 1 in 4 Americans are walking around dehydrated at any given time. So dehydration, trauma, hemorrhaging, burns, right? Okay. What At which vascular level does diffusion and osmosis occur? What you put? Capillaries. At the capillary level. That's the vascular level. What are varicose veins and what's the cause? Varicose veins are distended, stretched out veins that can no longer really, they don't have the integrity, the muscle wall, so they're stretched out. Why do they occur? Because of faulty valves in those veins. Any questions about that? Okay. Give a function for angiotensin. It is a vasoconstrictor, so it raises blood pressure. And epinephrine also, it initiates the fight or flight response, the sympathetic nervous system, but it also raises blood pressure, also raises blood contraction strength. We talked about terms, chronotropic versus ionotropic, so you guys knew those. I got these questions from your study guides. So if people have been looking at those study guides, I know you don't have time and time's valuable, but especially for a lot of you parents working, parents and working and all this stuff, but do try to see if you can augment your notes with your peers' notes, because collectively you guys are right on target. I saw that a lot of people were leaving the bonus blank. You know what that tells me? That you have to do what? Well, yes. Hormones. You've got to go back and get those hormones. There are going to be a lot of them on this next test. So ANF stands for atrial natriuretic factor. It is from the heart, and it lowers blood pressure. All right, so thanks for playing. So this is a study guide for everybody. Those of you who want to repeat your last quiz on the heart flow, you would want to do that. These 10 questions in bonus were just some of what we went over the other day, right? There was a lot of other stuff too, so make sure that you get that before going forward. Yes, Janet. They're not exact. They're actually not exactly the same thing. There can be different causes for them. So some of the hardening of the arteries can actually be because of ectopic ossification, where you're getting calcium laying down in the vessels, and some of it can be because of plaque formation. So like lipid balances off, and people have high cholesterol values can lead to that too. So, you know, how they use those terms, I think is probably just dependent on, I don't even know how they're distinguishing between.
Even in the
textbooks.
And our says to see
arterio, and then it says to see the other one. I can tell you that I have never heard anybody define one particularly because of a different reason, a particular reason. It's not like, oh, we haven't gotten to it yet, but we're going to learn about pneumothorax versus atelectasis. Those terms both mean a collapsed lung, but they mean collapsed lungs for very different reasons, right? So when we get to that, well, that's a little bit how I think about these two terms, but I've never in a clinical setting heard anybody truly define one over the other. I think they're almost interchangeable, you know? Yes. Is it hard trying to find one? Yeah. No, it's not hard to find an aneurysm if you do the right kind of testing, like MRIs can show them. But the problem with aneurysms is that most of us, they really do think that most of us have aneurysms, but they're never going to do anything. They're benign. But unless you look for them, you wouldn't see them. So most people who die from an aneurysm was never, you know, they don't do full body MRIs on people or scans on people because that would just be prohibitively expensive, right? So what happens is someone suddenly dies and then they figure out, oh, it had a ruptured aortic aneurysm, and they're usually abdominal aneurysms because they die really suddenly. But there was nothing to show that they had that, so they wouldn't have known. So you get what I mean? Or cerebral aneurysm that happens in the brain, and that's very sudden. That's a very sudden death. Did I answer your question? Mm-hmm. So they just don't know because you don't have signs of it. It's not like something you can go in and have your blood pressure taken. That's an easy thing to do. If people don't have their blood pressure routinely taken, that's just silly to not, because it's easy to do, but it's not easy to have full scans, you know, and whatever. And a lot of people don't know they have them until that's the cause of death. Okay. Have I ever given you a quiz back like that before? Feeling like I'm cheating a few of you. By doing that. Okay. So let's go ahead, and I want to bring to your attention something. Y'all know that Monday, maybe you didn't know this, but you're going to know now. So Monday, you're going to be doing a heart lab where you are labeling the heart. I had given you a list of structures. I'll make sure that if you want to look at those again today, it's the hearts today you can in lab, or you can look at the plastic models. Just make sure you know every one of those structures before Monday. We will also have a lecture quiz Monday on what we're doing today, so be prepared for both. And then obviously Wednesday, you have a multiple choice test on the cardiovascular system, hematology, heart, and vessels. Anything that we talked about, anything in a deeper insight, and anything in the disorders tables, any questions about how to study for that. Okay, now, the next time we meet after that, you're going to have another lab. Plus, you might have another lecture quiz with this, but let me show you what this lab is going to be. So I will have announced it. So what is this document recovery? I don't care. All right, look, because I think we pretty much had gotten through the physiology part of this chapter, which is really talking about like shock and talking about, you know, blood pressure and, you know, pulse rates and that sort of thing. But do you all see this? You see this picture. Now, this is slightly different from the pictures in your book, and some of you have old editions of the book and some newer, but I think it would be fair if I tell you that, because everybody has access to these PowerPoints, I put them up on the canvas, right? So I want you to go to the picture in the PowerPoint that says major systemic arteries, and I want you to add something to this, because I can't believe they didn't put this one. But I want you to add the carotid arteries. Everybody's heard of carotid arteries, haven't you? So I don't think that you probably already know your carotid arteries are here. So I want you to just, and you have internal and external, but anyway, just this group, the carotid arteries. Add it to this, and then this will be your word bank for the major arteries in the body. Now you might look at this and you might think, and then we're going to have, I'm going to show you another picture in a second. This is slide what? Slide 55. Okay, y'all add carotid arteries to this. This will be the day after our tests, you know, on the system, but you'll be labeling these. Am I going to give you an artery that's not on this list other than carotid? Because you're going to add that one? No, but this will be your list. It's not hard, because what does brachial mean? What does axillary mean? Underarm, right? What does radial? Radius, right? Radius is this bone here. Ulna is this bone, right? So you guys know these. Popliteal, what does that mean? Behind the knee, right? So that's that one. Now, there's another picture, because we know we don't just have arteries. We know that the arteries are taking blood to the capillary beds to feed the tissues and pick up waste products, but then blood comes back by way of what? Veins. So guess what else you have in this PowerPoint? You have major systemic veins. A picture. What slide is that? That's 67. And I want you to add one thing to the major systemic veins. I want you to add the jugulars, because jugulars are veins. And you know the veins are bringing blood back from the system to go back to which side of the heart? The right side of the heart, which is called the pulmonary circuit, because the right side of the heart is going to pump blood to where? The lungs. Like the back of your hand. You're going to know this, right? That how blood goes through the system. 2 pumps, closed vascular system, right? So if it's not on these slides, after you add carotid and jugular, I'm not going to have it in your word bank. okay? Or actually, I'm sorry about that. You're not going to have a word bank. You're going to have similar pictures that I have put asterisks beside what I want you to name. But would that be fair? Would I do something that I did wasn't on here? No. So these are the things you want to learn. The major systemic arteries and the major systemic veins. Yes.
Different bodies for arteries and veins.
Yes. Yeah, I am. But you all know that they're all, because it would just be too crowded to have them all, right? Yes. So I will have 2 different pictures.
And do we have a word bank for our heart?
No. Again, you will have like little asterisks. Would that be okay though, won't it? Right? Okay. Good question.
So when is the heart thing?
The heart is Monday. So just for y'all's schedule, the heart lab is Monday. The test on cardiovascular system is next Wednesday. And the Monday after that are these major vessels. Now, when we have these lab quizzes, are you also ready for lecture quizzes? But we don't have lecture quizzes on the days we have a test, right? That's just a reminder to people. How do y'all feel about this? You feel like you know what's coming up in the next couple of weeks? You're going to be able to be prepared for it? Are you? Certainly you have a ton of pictures that sort of break some of this stuff down. Some of this, though, we're going to address when we get to the organ systems. Like some of this we're going to, these are arterial pressure points, but anyway. But some of them, like a pulmonary, we're going to talk about that when we get to the respiratory system and the digestive system. We're going to look at the mesentery and, you know, whatever. So, but this is what you want to get from this now, right? All right, so you feel pretty good about that because I'm about to move on. So, now, you all get that this is starting new information. This won't be on the test next Wednesday. This will not be on the test next Wednesday. This information will be on a lecture quiz Monday, right? All right, so this is the lymphatic system that we're about to talk about, the lymphatic system. Y'all okay? Everybody good? Okay. All right, so the lymphatic system. I know y'all don't want to talk about the test after the cardiovascular system, but I'll just mention that the test after that is going to be, and I kind of told you all after endocrine and cardiovascular, it's really, my students have always thought that the rest of it, starting with this, is easier. You know, it's a little bit easier than those first 4 chapters. I can promise you, I've got about half of you all sitting there that don't know hormones. And you're, thank you for being honest about it, or whatever. I'm not saying you don't know anything about hormones. I'm just saying you don't know them well enough yet. So you know, it's okay, but I'm just giving you that heads up because sometimes we just need the reminder. You guys really need to put the time in for these, right? Are you leaving? Okay. Okay. So okay. All right, guys. But the next test after this will be on just lymphatic and respiratory. So we're going to have quite a few other tests. I know some people. I kind of look at y'all's grades, and almost everybody in here is about a letter grade less than they had last time. But after the first test, and this next test is not going to be so easy either, the cardiovascular system. So I just know that because of what I've seen students do in the past as far as average grades. And those first 2 tests can really dig you into a hole, so don't let that happen. I'm telling you, be prepared for next Wednesday. You have a week. So be prepared for that. Get those hormones in and get this information in. Okay. And then we'll have at least 3 other tests in this semester, plus the final exam. That has a lot of, it's half of the final exam's hormones, half of it. So okay, let's go ahead and start the lymphatic system. I do feel like this is the system that students know the least about coming in. maybe this one and the endocrine system. So I do want to give you that heads up so that you know some of this might be new to you. So I want you to be reasoning through it and spending enough time with it. The lymphatic system, when we think about the lymphatic system and immunity, when y'all hear the word immunity, what's another thing we can use for that? Immunity means that you have what?
Protection.
Protection. That's exactly. If you have immunity, you have protection. When we think about the lymphatic system, I want you guys to know that where y'all just saw major systemic arteries and major systemic veins, so think about a person with the skin removed. You know, we're very vascular, aren't we? But we have another entire vessel system there. We have another entire vascular system that is also part of this. Where's the picture? And it's little, this little guy is little, but this is what I call the lymphatic man, you know. But we have entire vessels. They look green here, where they made the arteries look red because of oxygenated blood, and they made the veins look blue because of deoxygenated blood. These vessels look green because they're carrying a fluid too, a very vital fluid. It's called lymph. And let me tell you what lymph is. Lymph is actually what you've heard me talk about it before, but I just didn't call it lymph. Lymph is that fluid that's bathing your tissues and bathing your cells. Didn't we say that all of your cells have fluids that are bathing them? There's an extracellular fluid. And then when we think about the fluid inside of our cells, what do we call that? Intracellular fluid, right? So our cells are three-dimensional because they're filled with fluid, aren't they? But our cells are bathed in fluid too. So all of our cells are being bathed in fluid. Where is that? What is that fluid? And where is that fluid coming from? Have you ever thought about it? Because you've heard me say since really day one in A&P 1, I talk about the fluid that's bathing your cells. And all of your cells have this extracellular fluid, right? So I want you to think about your little cells here. In this illustration, you see little cells with nuclei. You see them. And we understand they're filled with fluid, cytoplasm, and water is moving inside and out of the cells. What do we call the movement of water between two areas? We call that what? We call that osmosis. And we said what plays a huge role in how water moves is the osmolarity, the percent of solutes that are in the solution between those two places. So do we want osmolarity sort of staying balanced in our intracellular fluid, our extracellular fluid? And then where does the extracellular fluid come from? What did you all say this is right here? We just looked at them. What is this? What is this right here? It's probably labeled. It is. These are capillary beds, right? And we said blood comes in these capillary beds and diffusion and osmosis can occur. Then we say at this capillary bed level. So the fluid that's bathing your cells is coming from blood plasma. That's where it comes from. It comes from blood plasma, which is mostly what? Water. That makes good sense to me. Does it make good sense to you, Brittany? Mm-hmm. That makes really good sense to me that the fluid, the blood plasma, the water can move out of the capillary beds into our tissue spaces. But wait a minute. When it's moving into our tissue spaces, where's the water going that was already there? Right. So it's got this pressure being exerted on it, and it's entering into what are called lymphatic capillaries. A difference in the lymphatic capillaries anatomically from the blood capillaries is I want you all to look at this picture. Lymphatic capillaries, they're not like blood capillaries that are continuous, where the blood capillaries, oxygenated blood comes in, gives off the oxygen, picks up CO2, and continues on, right? Lymphatic capillaries are closed at one end. These lymphatic capillaries are closed at one end. And that means, see if it doesn't make sense, that means that as water is pressing and bathing these cells, it will move into this closed capillary, lymphatic capillary, and the pressure of that will push it in one direction. Does that make sense? Does it? So let me tell you what lymph is. It's a fluid that's very similar to blood plasma. And we said blood plasma is mostly what? Would you say what? It's mostly water. It's mostly water. But it even has a lot less proteins in it blood plasma. So it's very similar to blood plasma, but with many less really solids, many less proteins. So it's bathing these cells. Can you picture that?
So it's going in and out of them too. It's inside of them too.
So water is moving in and out of even within our cells and out. But as it's also moving out of our blood capillary beds, it's being forced into these lymphatic vessels. And this is called lymphatic return, right?
So what do the capillaries do?
What do the lymphatic capillaries do? They're closed at this end, so they capture lymph. They capture the water that's bathing our cells. I want you all to think about a little pond or a pool or a little stream. If water were just over the rocks in the pond and the water never moved, what would happen? It really would not be a healthy ecosystem, would it? What do you have to keep it doing? Flowing and moving. Doesn't it make sense that, you think you bite a hangnail, right? You bite a hangnail. Your mouth, I mean, we've got bacteria everywhere, don't we, in our skin, or we floss our teeth too hard, or we stump our toe. Once something's breached, that of our tissues are breached, then obviously microbes, which are normal, but they can get into our tissues. And is that going to be okay? That's going to be okay because we have this fluid that's bathing our cells, and some of it is going to actually just be lost out, right? But it's okay even if it gets into the lymphatic vessels, because it's going to be bathed, and in the lymphatic vessels, let me tell you what's going to happen. In the lymphatic vessels, as the fluid moves through lymphatic vessels, now look at this guy's vessel. He just stumped his toe, right, really hard, and I don't know, or stepped on a nail, whatever. So he stepped on something. And that's okay. Those tissues are damaged. They are damaged. Swelling is going to occur. More fluid's going to come to the site, isn't it? More fluid's going to come to the site. And the fluid that's there is going to be pushed into the lymphatic vessels. These capillaries turn into larger and larger vessels. And if you notice through this little lymphatic man, you probably can't see it from the back, but if you notice, interspersed here are these little organs called lymph nodes. And that lymph from a particular region has to go through quite a few lymph nodes. So what is the function of a lymph node? Let's look at this area just of the breast here, and we see the lymphatic drainage for this particular region. We can, it's sort of showing us what an illustration of it would be. And the lymph return goes through nodes. It's all this lymph is having to go through nodes. Maybe it would make sense to you, maybe it wouldn't, but maybe it would make sense to you that lymph node has a function. And the lymph node's function, as lymph is coming through, is to hold that fluid for a bit of time, make that fluid go through these little ducts, almost like mazes, and in the mazes are white cells. And what do you know white cells do? They protect us. In this particular case, these lymphocytes, have y'all heard of lymphocytes? Have you heard of macrophages? Have you heard of those? Right? These lymphocytes, macrophages, a big eater, right? Monocyte derived big eaters. They're going to detect if there's anything foreign. And guess what they're going to do while it's in the node?
Kill it.
Destroy it. Because do they want it getting past the node to the next node? Hopefully it won't, right? So as these afferent vessels, afferent just means it's bringing lymph here, the lymph is kind of backing up, and that's what it's supposed to do. And anything that's foreign will hopefully be cleared here. So the function of a lymph node is to clear lymph of any potential pathogens. Does that make sense? Before letting that lymph go to the next area. Does that make sense to you? Does it make sense to you that he stepped on a nail right here? I'm making it more and more dangerous every time I talk about it. Stepped on a nail right here, which, I don't care if it's a brand new nail. Is it sterile? Not likely. Because it wouldn't be anyway, because his skin's not sterile. So he just shoved all this stuff up into his tissues, right, that are being bathed by a fluid. But that's okay, because it's going to move through the lymphatic vessels. get to these nodes, and if the first one doesn't catch it, kill it all, then by the time it gets to the next node or the one after that or the one after that, you hope it's clear. Because let me tell you where lymph is heading. And this is important for you to know. Lymph is moving through these vessels, moving through all of these nodes, being filtered, and it's going to be returned back to the bloodstream. It's being returned back to the bloodstream. Hey guys, did I tell you all that it's important that the osmolarity of your blood be just right, that the viscosity of your blood be just right? Did I tell y'all that's important? Did I tell you it's important that you know your hematocrit, because your red cell count plays a huge role in it, but also the proteins from your liver and other proteins are also playing, like albumin, are playing a huge role in viscosity. But you've got to have enough fluid part, because most of whole blood is what? Water, which is what most of plasma is, isn't it? So if you weren't getting enough lymphatic return back, if you weren't getting enough lymph back to the bloodstream, do you think that would affect your blood volume? Do you? Mm-hmm. Yeah, it definitely would. So all of this is interwoven here. Do you have any questions for me so far?
So is that whole thing lymphatic return? The whole process?
Yeah, that's referring to lymphatic return. All right, so let me ask you something. If I were to ask you what is lymph, what would you say? So lymph is actually this clear kind of colorless fluid, very similar to blood plasma, but with a lot less of the proteins. But then I would say, like, where does lymph come from? And what did you just say, Casey? It comes from where? Where does lymph come from? It comes from blood plasma. From the blood capillary beds, plasma, water is moving out to bathe our cells. The water that was already there is continuing to flow. Because y'all said that is the only thing that you can think of would be a healthy kind of system, and that's really true. That it's continuing to be recycled. The water is continuing to be recycled. So where does lymph get returned back to? Bloodstream. It gets returned back to the bloodstream. This entire, almost 80% really of your body, it gets returned back here into this left subclavian vein. And then this little right part, there's a right part here, it gets returned back into this area. But it enters back at the subclavian vein, which y'all might not know what the subclavian vein is right now, but you will after you look at the vessels. Subclavian, that's exactly right. And you will after the, thank you, because we use all that to help us. So it gets returned back. Do we want it being returned back? What would happen, since we know every one of our cells, every one of our cells have to be bathed, right? Internally. What would happen if all of a sudden you could, and blood vessels are actually nourishing, because if the blood capillaries get compromised, then your cells are going to die. There's going to be necrosis and your cells are going to die. But so you're getting blood supply, but what happens if the lymphatic return is impaired is that the lymph is backing up. And so now you're getting this edema, right? Yes, Casey?
Where does it get returned? I know it gets returned to the bloodstream.
At the subclavian vein. Okay, so I hope, how many of you would say you didn't really know about lymphatic vessels? Like you knew arteries, you knew veins. And see, I have a lot of students who say, well, you know, I've never just really thought about like that there's a whole nother vascular system here. And this would be important to know, because if anybody ever goes into surgery or, you know, is going to help in an OR process, are they having to, when they open somebody up, certainly look for nerves, peripheral nerves, that you got to know where those are, but also where the arteries, veins, and lymphatic vessels. So be able to distinguish. Because by the way, when you open somebody up, the arteries are going to be pretty apparent. The veins are going to be pretty apparent. But, you know, some of these other structures aren't so much because they're not colored for you. You know, we've got a green up here, don't we? But they don't really look like that way when you're looking at somebody. So I want to go back a second to this particular area, because I want to just impress upon you that every tissue you have has blood capillary supply. and also lymphatic vessels that are going to be picking up the lymph and returning it back to the bloodstream. So what happens when somebody has like a lumpectomy or a mastectomy? Lumpectomies are talking about like breast cancer, right? And probably everybody in this room knows somebody who has had this procedure done. When someone has cancer, do they, surgery is an option, so they go in and actually perform surgery. Did they ever just remove just the cancer? No, what do they take? They take a margin surrounding tissues, but then they also, y'all have heard that they take what? You've heard that they take lymph nodes, haven't you, Jan? Heard this. So why do they do that? Let me tell you why. Y'all told me nobody has ever really died of cancer. They die because the cancer is malignant and it does what? Spreads. It metastasizes. So they die because of metastatic reasons, that the cancer has left the site that it originated in and is now gone to other regions, the bone, the brain, the liver, it's gone other places. That's why they die. If cancers would stay where they were, then it would. But we said one of the signs of malignancies is that the cancer where it originates is not encapsulated, meaning that it's not contained. And so it has a pretty high chance of a cell breaking away. And when a cell breaks away from a malignancy, how do you think it gets to the other sites? Through what system? Well, it starts with the lymphatic system, and we think most of it, that's how it happens. The cell will get into the lymphatic system, move through the lymph nodes, and then where is it? Then where does it get to? Where does the lymph get returned? Bloodstream. And then once it's in the bloodstream, guess what?
It's over.
It's usually game over. Do you get what I'm saying? So this is why when they remove cancer, they remove a margin, but they also, while they're in there doing this, they put dye, they put a drop of dye and they watch, macroscopically, they watch and they see which lymph node is the first node that dye drains to. They can see the dye. And that's called the guardian or sentinel node. And then they'll look to see where it's going from there, and they'll take those nodes. Depending on how aggressive they think the cancer might be, they will take a certain percent of nodes. And what are they going to do with those nodes? They're going to take them, send them to pathology. They're going to do histology slides. They're going to look for cancer in the lymph nodes. If there's cancer cells in the lymph nodes, what happens to prognosis?
It's not good.
Yeah, prognosis goes down, right? You're kind of, if you see no node involvement, are you feeling pretty good? You're feeling really pretty good. Or if you've got really low nodes, meaning the sentinel node might have had detectable cancer in it, but the other nodes were negative, right? Then this is all of how they stage cancers.
So the guardian node is first node.
Yeah, the guardian or sentinel node from the site where it's draining. That's guardian just means like, that's guarding that site, or sentinel means the first. Well, I don't know what sentinel means. What does it mean? I just associate it with meaning like protection, right? Guardian or sentinel node. So how many of you know people who had the nodes removed and they get checked, don't they? And then you really like to hear that there was no node. Now, just because you get the report that there were no cancer found in the nodes, does it mean that it hasn't spread? No, it just means that it wasn't detected, and that's actually a good report. You're hoping for that, but it doesn't mean that it might not have spread. And just but that is the report you would want to hear. Am I making sense? Everybody's listening. All right, so all of our tissues have this lymphatic return, and we have to have it. Is this affecting blood volume? Is this affecting the health of your tissues? Is this just affecting a lot of things, right? So, so great. We kind of get that. And when we think about these, when we think about the routes, we get that they're capillaries They're capillaries that are closed at one end, and that's why the lymph must go into there. When water's moving out of the blood capillaries, there's a certain amount of pressure behind it. So because these lymphatic capillaries are closed at one end, it will go in there, and that pressure is going to keep it moving. So think about that lymph that's right now bathing your toes. Think about that. Do you feel it? No. Okay. But you can feel it. Well, you can't feel it. But there's this lymph bathing your toes. How is that lymph going to get all the way back to your subclavian veins? How does that happen?
Blood pressure.
Because in lymphatic vessels, we have something that can help it keep going in one direction. They really are called valves, but it's also that what would help it? What would encourage lymph to keep flowing if you're doing what? Just moving. Just moving. Is that right? So not only do we want to stay active, continue to move because of right venous blood return, because we said the blood pressure in systemic veins is pretty low, isn't it? But we also want to keep moving for our what return? Lymph return. Does that make good sense to everybody? And sometimes we really are in positions now where we have occupations where we're sitting long periods of time that can interrupt this. We are standing for maybe too still for long periods of time on hard, unnatural surfaces. So if we can just keep moving, this is really healthy for us to do. Do y'all have any questions for me? Do y'all have any questions for me at this point? I have put some things on your visible body, and I have put some things up on your visible body that, the visible body things are just for y'all. But there's some really cool stuff on there. There's some animation. Claire's shaking her head. Have you seen them? There's some animation. There's way more anatomy than we have time to do in here. But it can really help you to understand this, to get a better understanding. So I haven't really assigned anything that I'm saying that, prove to me you did it. But I can actually see when people go in. I can see when people have gone in and how much time they're in there and what they look at. So I get to see that. But I haven't done any assignments. They're just for you, and I hope you'll use them. You had a question? And yes.
So can you go over blood capillary, and then does the lymph system, so blood capillary vessels drop off blood, and then how does that all intertwine?
Okay. All right. And Blair, what was your question?
I was just wondering how does the lymph fluid stay in that while it's traveling up to the lymph nodes? You know what I'm saying? Why doesn't it diffuse back out?
The pressure. Okay, that's really a great question. So as let me answer them both at the same time as I explain this again, and I don't know if I will, but let me know if you still have questions afterwards. So I'm going to go back over this a little bit, and this picture might be a good visual for you. I'm a visual learner, so I like these kind of things. But if you're not, if you're audio learner, listen to what I'm saying. Make sure that you do understand this. So we understood, because we already had this, that the left pumps blood to all of our system's tissues, all of our tissues. And where those nutrients and waste products get exchanged is at this blood capillary bed level. Are we good so far? But we said it's not just nutrients like solids, like gases and, glucose and things like that, hormones. It's not just that that's moving across the tissues. It's also water. Water is moving out of these blood capillary beds. We know that blood is mostly water. Blood plasma, isn't it? And plasma is mostly water. So we know that water will be moving out as well. And as water is moving out, there is a pressure associated with it that is going to be moving the water that's already there. And that's going to move some of that water into these lymphatic capillaries. These lymphatic capillaries are one cell layer thick, just like the blood capillaries are. So there's still some movement of water both directions. There really is. Water is always moving. Nothing is really ever stagnant. So there's still a little bit of that. But what is happening is there's enough pressure to get it to these larger vessels that now have very much the same anatomy as veins do. Is there any leakage of water from veins? No, it's at the capillary level. So now there can't be this once it gets to this. Now, let me say this. There's several factors leading to the pressure that's enough to return lymph to the bloodstream. Some of that pressure is because of this. Now, y'all just, instead of writing, just listen to this. You have, and I want you to try to visualize this amount of pressure. I want you to forget this for a minute. I want you to think about hiking in the woods. Maybe you've hiked where there's elevation. I don't know. But when you've been hiking, have you ever come across a little tiny stream? Have you? Little tiny stream. And you fell in a stream and you could follow it, right? And it's not, you know, just intuitively, it's not the only little stream out there with you. But you've got this little water stream. Maybe it's, you know, spring-fed. I don't know. You got this little stream. And if you followed it, what would it eventually get to? A creek. And is the creek larger?
Yes.
And is the creek running faster?
Yes.
Why?
Bigger, larger.
No, that's not it. It's bigger, larger.
It has more
But it's
pressure.
because you know there are more streams feeding it. And as more feeding it, is that actually encouraging the flow?
Yes.
Do you get what I mean? So I want y'all to realize these lymphatic capillaries, they're so numerous and the pressure is really low, just like a little stream. But as it gets to fewer but larger vessels, they're all pushing it behind it. Do you get what I'm saying? So this is kind of pushing behind it, keeping the flow going. It really is. You get what I mean? And by the time the creek you followed, you got to what? And what is that thing doing? That's really flowing, isn't it? Now, it's not really so much of the pressure's increasing, obviously, at those extreme things, but this is contributing to the pressure being able to push it to fewer vessels that are being contributed to by a lot of these small ones, and is pushing it. Everything is pushing behind it. So did that answer your question? Now, once the vessels are actually, and did it answer yours? Because once the vessels are actually, and this is talking a little bit about the flow, and it's very low, but there's valves that are helping it to only go in one direction. There's valves helping it to do that. We're moving, which muscles are, Casey, muscles are, our skeletal muscles are pumping it, almost milking those vessels, right? Which we said do it. And if you're exercising, that's really helping with venous return. So these are all mechanisms that help with that. And the actual vessels themselves are very much like, I was looking for the, it's somewhere. Here it is. So you've got these collecting that end up going into larger trunks, right? So you've got these areas that are now have a ton of lymph in them. And that's just helping it to move. And the vessels themselves have very much the same anatomy as blood veins, where they have a muscle layer middle wall. Can smooth muscle contract? If smooth muscle is contracting, this is what happens with exercise. When people are exercising, this is helping with the right venous return, but also the lymphatic return, which is helping with blood volume, keeping blood volume up. Because these smooth muscles are getting this signal to do this little rhythmic kinds of contracting. And can that help to move it along? Will it help to move it along? It will. So did I answer those two questions? Did that cause any more questions? Because that would be good if it did. It'd be even better if I can answer them. I hope I can answer them. So again, look at just the lymph nodes. You can see this with the lymph nodes. You have lots of afferent vessels, little streams, if you will, bringing blood into a lymph, lymph into a lymph node. But you can see where there's only a limited number of vessels where the lymph exits. So what is that going to, just the anatomy tells you that lymph is going to do what here? it's gonna back up a little bit, right? But more pressure's coming in, so the pressure coming out, it is sending it out here. But it's gonna stay here for long enough that lymphocytes and macrophages can detect anything that might be foreign there and hopefully take care of it there. Now, what happens when a lymph node, why do lymph nodes swell? We've all had swollen lymph nodes. Have we all had swollen lymph nodes? Because the lymphs are doing their job. The lymph nodes are doing their job. They've detected that there's something foreign. And do you think these cells just send on the information, or do they send out sirens? They send out sirens. And when they send out sirens in the form of what kind of molecules? Hormones. When they really are, they're signaling molecules. It'll call more white blood cells to the site. It will call more fluid. It will cause more fluid to build up here, and these lymph nodes will swell. A swollen lymph node is a working lymph node. Now, can lymph nodes get too big?
Yes.
Can they? And does it take a long time for lymph nodes? You'll be well way before your lymph nodes go down. You know what I mean? Because it can take a long time for a lymph node to drain. We said the pressure's not so great anyway, so it can take a long time. It can take weeks, even months, for a lymph node to actually get one that had been active, one that had worked, one that was doing its job, one that you were glad it hurt you. You were glad it was hurting because you knew it was doing what? It was working. It was doing its job. It can take a long time. Sometimes they can get too swollen, and sometimes they can actually, you worry about them a little bit. So sometimes they will, remove lymph nodes if they have to. They would remove them if it gotten too big. Sometimes they're doing that because they're trying to biopsy it too. Now, I wanted to tell you something, one other thing, and see if this doesn't make sense to you. I wish this picture were bigger, but y'all have your picture in your book. And obviously it's not, you can only see a two-dimensional aspect here. On that visible body, you can turn them around and you can see all the little lymph nodes, where they are, where they're located. Why do you think we have so many lymph nodes here where I'm pointing? Why do you think we have so many here? Why do you think we have so many here? Why do you think we do have them here and have them here? Because we step on things, we work with our hands, we injure our hands, and if they get by here, that's okay because we're going to have more of them where? In the axillary region. And why do we have so many here and in the inguinal region? Why? Well, that's true, but why do we have? Because we have openings here, don't we? We have portals of entry here, and we have portals of entry here, right? But that is true, right? Is that true? That makes perfect sense. We also have a ton of them. That's very scientific, but whatever, isn't to say a ton. But we also have aggregates of them, that's what they call them, near our small intestines where it enters the large intestines, where food is going to go from the small intestines and then enters into the large intestines. That's typically on most people in this lower right quadrant. We have a ton of, we have patches of nodes here too. And that kind of makes sense to us too, because what do we know our colon, our large intestines, should be filled with? Well, there's one. Our large intestines carries out its functions by bacterial enzymes. Our large intestines, our colon is filled with microorganisms, and it's supposed to be. 95% of the dry weight of your stool is microbial. You have bacteria, you have fungi, you have all kinds of microbes living in your colon, and you're happy about it. If those microbes get out of balance, you're going to be sick. Maybe life-threateningly sick. This is why taking antibiotics when you don't need them, or doing things that can interrupt the microbes that are in your colon, are just horrible for you. They really are, because those microbes are what are keeping you healthy and alive. But because the large intestines, the colon, is so filled with microbes, that area where the food is first entering into that colon, it's a little bit of an Achilles heel area. And so there's plenty of lymph nodes there, so that if something did escape into the peritoneal cavity, it might not kill you. But anyway, so it's just a protection. These protect us. Look, what else are we born with that can protect us? So we've got these. Oh, well, wait a minute. Well, I haven't finished with it. Yeah, we're kind of finished with the lymphatic vessels. So do you have any questions about what lymph is? Where does it come from? Blood plasma, doesn't it? From blood capillary beds, from blood plasma. Where is it returned back to? The bloodstream. It's returned back to blood plasma. So if we don't have this continual cycle going, would this affect blood volume? This would even affect blood volume. So we've got to have this continual thing going so we get this. Did Sarah, did you or Blair had this in your AP1? Did y'all have the lymphatic system? So no, okay. All right. So I want to talk to you about some other things, and this is the tonsils. I want you to know that you have different sets of tonsils. Most of the time when people say, talk about their tonsils, they're talking about palatine tonsils. The palatine tonsils are the tonsils that you see on the sides of the pharynx, the throat. The palatine tonsils, when somebody says, say ah. Okay.
I shouldn't be in
I was going to say, I don't see anything, but it's also like shadowed in there. So when somebody says ah, you see those palatine tonsils. You also have tonsils on the back of your tongue. So those are called lingual tonsils. And then you have tonsils on that whole back wall of your pharynx. Those are called, people call those adenoids, but they are pharyngeal tonsils. So you have these different kinds of tonsils. So what do tonsils do? Do they just cause you trouble? Is that what they do? How many have had their tonsils out other than Dylan? Wow. Raise your hands again. Wow. Wow. Okay. I'm surprised it's that many. Okay. How many of you had adenoids out? So here's the thing. Your tonsils are part of your immune system. Your tonsils are necessary. They do a great job. These tonsils, the reason you have them in this area is, I said, this is a portal of entry for most particular pathogens, right? And we have to have a way to be able to take in nutrients, don't we, and all kinds of other functions like respiratory and those kinds of functions. But this is also a portal of entry. So that's okay because you've got these tonsils. And tonsils have normally what are called crypts. And a crypt is just something that can trap something, isn't it? So if you encounter pathogens, they can be caught here, and that's okay, because in these crypts, you're going to see these nodules where you're going to have a lot of white cells, lymphocytes, and other cells that are going to be there to recognize something that could be a potential pathogen and destroy it right then. Tonsillitis means what? Yeah, so inflammation of the tonsils. So, and probably most of us have had tonsillitis sometime in our life. We've had that, but we haven't had it so recurring that we had to have our tonsils out. Now, people who have recurring tonsillitis, meaning and it's usually the palatine. The palatine tonsils are staying inflamed, which means that they're staying reactive. They're staying swollen. There's probably, exudates here. There's infection there. It can even lead to what's called peritonsillar abscesses. Now, tonsillar abscesses are no joke, because if there's an abscess, there's so much blood supply here. Where could that infection get to? The brain or bloodstream. So that's a really serious thing. But people who have recurring tonsillitis or tonsils that are staying enlarged, the tonsils themselves can start to become uncrowded. And if the tonsils start to become that way, then instead of what good they're doing for you, they're causing you some risk too, right? So now they're kind of harboring infections. And so that's when they try to make that decision to remove the tonsils if they have to.
What did you call it? They become what? What do they become? Necrotic.
They can become so, they just had so many recurring infections that now they're like seeding infections, and then it becomes a problem. Y'all have probably seen people who have what they call cryptic tonsils, but I don't like it being called that because all tonsils have crypts in them. But y'all have seen people who say, and it looks like they have these big divots in their tonsils. So much so that they get like tonsil stones. Have y'all seen tonsil stones before? Where they have such big divots in their tonsils because of recurring infections that food and fungi and things get trapped and it can turn into what's called a stone. And so that, has anybody ever seen these? And some people who get these can just pop them out, and what's left behind is the crypt, and then it's going to just form again, So, but I don't want you to think about your tonsils as being bad. I want you to think about tonsils as being really good things. So, and because they are, they're part of your immune system, and they can really serve a function in helping us. But if they end up blocking your airway, is that a problem? You'll hear tonsils referred to as kissing tonsils, where somebody says, you'll see the little uvula. The uvula is that little dangler in the back of the throat. And somebody says, because if the cranial nerves are working like they should go forward. But you'll see their tonsils rotate on each other, and they'll actually block the airway when somebody's doing that. Okay, that's too big. Too big of tonsils. And if it's causing any kind of apnea issues, or whatever, then they need to go. The same thing can happen. Same thing can happen with the pharyngeal tonsils.
That's what brings me that. She didn't get her tonsils out. Hers were kissing tonsils.
Yeah, so they touched, and it was just interfering with airflow. Yeah, and I'll also just briefly, and you don't need to know this, but I'll just tell you, make sure you know these 3 tonsils, where they would be. Anyway. Oh, no, I do want to tell you this, because this is, I'm guilty of this. I'm guilty of this because I worked in pediatric infectious disease specifically for many of the years I was doing infectious diseases. And, little kids can have their tonsils out when they're little, and, they hardly stop skipping. They really do pretty well unless something happened, whatever. And then you'll see adults have their tonsils out, and oh my God, you would just think that they had, I don't know. Yeah, like that. Okay, but here's what an ENT told me, and then I had to feel bad about how I felt about adults having their tonsils out. And I believe this person, it truly is a worse procedure for an adult. Post-puberty, getting your tonsils out is a worse surgical procedure for that person. So because of the what they're doing anatomically to you in that procedure, it's a harder recovery. So then I was feeling bad to think that the adults were just being whiners. You know what I mean? It's just easier for the kids. But they are careful about removing tonsils for no reason, because we went through these periods of time where we were removing too many tonsils. And you've got to wonder what that might set people up for later. A study came out in the, I guess it was the late 80s, a study came out that said that especially young boys who had their tonsils removed before they were 6 had a much higher incidence of developing lymphoma as young adults, cancer of the lymphatic system as young adults. Okay, now wait a minute. Then at about the same time, a study came out that said that any kid who had their tonsils out was higher at risk for developing type 1 diabetes, which is autoimmune disease. So guess what ENTs stopped doing? They did. You couldn't get an ENT to remove a tonsil in the late 80s because these studies had made it seem like that this was really linked. But with more studies and more information and more retrospective look at it, they debunked that. So then what happened in the next 10 years is we had all these young adults who should have had their tonsils out, but didn't because the ENTs were not touching tonsils, right? And then they became young adults still having serious tonsil issues that had to have their tonsils out, so then we saw the numbers go up, whatever. That happens. We live and we learn, right? So anyway. All right, the thymus gland. Have you all already learned about the thymus gland? So in this young child, you can tell this little young child from his little shoulders. This young child, the thymus is huge, but as we age, what happens to the thymus? It starts, so it starts to involute. But the thymus is an important gland. It secretes these hormones that we know target the T lymphocytes that are going to help with the maturation of those T lymphocytes. School them, if you will, so that they become competent cells in the peripheral blood and can protect us. So we talked about lymphocytes. We know circulating lymphocytes are about 30, and for adults, about 30+%, unless you have lymphocytosis, but they're about 30+%. And we know that, anyway, a portion of those, a good portion of those, more than half of those lymphocytes are T lymphocytes. And they're called that because they're dependent on the hormones from the thymus gland. That's why they're this category. Now we're going to learn that they're not all T lymphocytes are equal. They're going to be different kinds of T lymphocytes. Are y'all going to have to know their functions? You all are going to have to know their functions. So we get that. The spleen, I want you to know the spleen is usually in this, on this left side. It's usually dorsal and inferior to the stomach. So, and it's on this also, so that's usually where the spleen is. When we do rat dissections, y'all are going to see. The thing about rats is some things are very similar, except much tinier in a rat than in an adult. But the spleen is very much like a human spleen. The lungs aren't alike too. Well, they're enough alike. The intestines are nothing alike. But the kidneys and the spleen are very much like humans, and you will see this. But anyway, the spleen carries out the function of acting as a blood reservoir. I think we've talked about this. Acting as a blood reservoir, it filters blood. So because it acts as a blood reservoir, it's one of the first sites if somebody has a viral infection or some sort of infection where this is going to be detected. So the spleen is going to play a huge role in the immune system. Can you live without your spleen? Having a splenectomy. Actomy means what? Removal. If you haven't had a splenectomy, can you live? Sure you can. But you are forevermore immunocompromised. If somebody is living without a spleen, they need to pay attention and understand that they are much more at risk for opportunistic infections. They're much more at risk of dying from something that a person with a strong immune system wouldn't. So they have to get their immunizations, don't they? They have to be really proactive in protecting themselves and keeping their immune system as strong as they can, because they're already at a deficit by not having a spleen. So we get that this is what the functions of the spleen is, removing old and warm red blood cells. That we had learned this in hematology. So here's what I want to just briefly introduce you to before we take a break and then have lab with our blood pressures and pulses. I want to introduce you to the idea that you have, and I'm probably not so much going to use this slides, but I'm just going to talk about this the next time we get together. When we think about immunity, we think about non-specific and specific. But I want you to have heard a different term for these two, because I think you will on these tests that you take, right? So of the non-specific, this is sometimes referred to as innate. Innate means what? What does innate mean?
Like
Innate. Innate. I-N-N-A-T-E. Innate means what? It means you're born with it. You're born with this. You're at birth, you had this, innate. So you're born with some of these non-specific things. Are we born with lymphatic vessels? Are we born with tonsils? Are we born with spleens? Are we born with thymuses? So those are innate, aren't they? How about skin? Is that protected? How about nose hairs and eyelashes and eyebrows? Are they protected? How about tears? Are they protected? Mucus, is that protected? Those are things we're all born with. What are some other things we're born with that protect us? Nobody? Things that we're born with that can protect us. We make saliva. Is that protective? It actually is. Saliva is protective. We actually didn't, I mean, this is kind of whatever, but it's true. We urinate frequently. Does that keep our urethral orifices clear? Just the act of urinating. How about the act of defecating, getting rid of what wasn't able to be absorbed? Isn't that protective, to be able to get rid of what can't be absorbed? Right? So those acts are protected, that we're just born with those, that's innate, isn't it? We could probably make something up, and it would be, if we're born with it, then it would be part of our protection, wouldn't it? But all those things. How about fever? Can most of us have, develop an increase in our temperature? We call fever. Is that protected? It is. It's protected. Being able to change your temperature is actually protected. And we'll talk about more why later. So that's non-specific. And y'all would give me some of those examples of non-specific, just things you're born with that protect you. And then you have what's called specific immunity that is sometimes called in other circumstances adaptive immunity. Because when we think about adaptive, what does that suggest to you?
You developed it over time.
Yeah, you develop this over time. So this is specific or adaptive immunity. Please keep in mind, I can't talk about them both at the same time. So first when we come back here on Monday, we'll talk about the non-specific first and get through that. Some more non-specific examples. But this entire chapter is really about adaptive specific immunity. If we didn't have adaptive specific immunity, if we didn't have that, we wouldn't get out of infancy. None of us would exist. By the way, the people who have very compromised specific immunity have to live in bubbles. Have y'all heard of the little boys in bubbles who have to live in a sterile world? That's because they don't have specific immunity. So are we going to be impressed when we get to the specific immunity topics and content and realize we've got to understand how that's happening, right? Because it allows us to live in this microbial world. We are just guests in this microbial world we're living in. And without specific immunity, we wouldn't be here. So that's what you get to look forward to. Are you excited on Monday? Hey guys, you got your 1 by for your quiz, didn't you? That was your 1 by. So you going to get any more? I didn't want to write it anyway. I really didn't. So look, so let's take a 15-minute break, if you will. Then we're going to come back in and do blood pressures. How many people do blood pressures in here for like? I got EMTs, I got nurses, I got you guys. So you all are going to help. You're going to maybe do somebody, show them. I'll show the first 1 or 2, and then we'll do somebody, and then you'll let them do 2 movies or whatever. You'll help me with this. Okay.